Imagine struggling to reach for that top shelf or, feeling that sharp twinge just as you serve a tennis ball.
Hmm,
Shoulder pain isn't just an inconvenience. It can really sideline you from daily life and, well, peak performance too.
absolutely.
It's incredibly common, isn't it? But have you ever wondered why specific movements seem to trigger the pain?
It's a good question.
Or how something you do completely unrelated to sport, like maybe even playing video games, could actually be making you more vulnerable?
That's a fascinating angle, and one the research does touch on, surprisingly.
Welcome to the deep dive. Our mission here is to take that stack of sources you've shared, all the research, the articles, your notes, and really sift through them.
Mm-hmm.
We want to pull out the most important nuggets, essentially giving you the shortcut to being truly well-informed on a topic that matters to you.
A very useful service.
Today, we're taking a deep dive into the complex world of the shoulder joint. We'll look at how it works, the common ways it gets injured, things like torn rotator cuffs, frozen shoulders, instability.
The usual suspects.
Exactly. And the latest science guiding how we diagnose and treat these issues. To guide us through all this rich material, we're joined by a true expert.
Well, it's a pleasure to be here and explore this fascinating area. The shoulder really is a masterpiece of biomechanics, isn't it?
It really is.
But its complexity that also makes it prone to problems. And the sources you've gathered provide a really comprehensive look, I think. They marry fundamental anatomy with modern clinical insights and, as you said, some quite surprising research findings.
Yes, definitely.
My own background is in orthopedics, with a particular focus on understanding shoulder function, injury mechanisms, and outcomes, drawing on both, well, clinical practice and research. So I'm ready to unpack what these materials reveal.
Brilliant. Okay, let's kick off then with just a few quick questions to set the stage.
Fire away.
Firstly, when we talk about shoulder stability, we often think of muscles, right?
We do, yes. The dynamic stabilizers.
But what are the crucial passive elements, the things that hold the shoulder in place, especially when it's moving through that huge range of motion it has?
Ah, that's a critical distinction. You're right. Muscles provide the dynamic control, the active stability, but the passive stability comes primarily from the joint capsule itself and the ligaments,
Okay.
especially that complex inferior glenohumeral ligament. These structures, they become taut. They tighten up right at the end ranges of motion. They act a bit like check reins, to prevent dislocation.
Right, like a physical stop.
Exactly.
Right.
But perhaps less intuitively, there's also a significant role played by the negative pressure within the joint.
Negative pressure.
Yes, essentially a suction effect.
Right.
It helps keep the ball, the humeral head, centered in the socket. And this is particularly important in the mid-range of movement, not just at the extremes.
Like a sort of sealed environment creating a bit of a vacuum.
Precisely that, yes.
Yeah.
It relies on the joint space being contained and having the right characteristics, the right volume, the right capsular properties.
Fascinating. I hadn't really thought about that suction effect before. Okay, second question. Rotator cuff tears. They sound quite serious.
They certainly can be.
Is the treatment always surgical, or does it really depend on the specific tear itself?
Oh, it absolutely depends. The decision is highly individualized. You have to consider the patient's age, their activity level, and the specific characteristics of the tear, its size, the type of tear, and crucially, the quality of the muscle tissue involved. Is it healthy or starting to waste away?
Okay, so it's not one size fits all.
Not at all. While surgery is necessary in many cases, yes, conservative treatment, things like physio, maybe injections is often the first step and can actually be quite successful for certain types of tears.
Good to know there are options. And finally, frozen shoulder. Is that just a general term people use for any stiff shoulder, or is it a distinct medical condition?
It's definitely a distinct medical condition. According to current expert consensus, frozen shoulder refers specifically to what's called primary idiopathic stiff shoulder.
Idiopathic meaning we don't know the cause.
Exactly. And primary meaning it arises on its own, not secondary to something else like trauma or surgery.
Yeah.
Now, terms you might hear, like periarthritis or the classic adhesive capsulitis.
Yes, I've heard adhesive capsulitis a lot.
Right. Well, they're actually considered inaccurate now by expert groups like ISCOS. And the reason is the main pathology isn't primarily inflammation, like itis suggests.
Ah, okay.
And it's not usually due to widespread sticky adhesions between the main joint surfaces, which is what adhesive implies, and is a common misunderstanding.
So it's a precise diagnosis with very specific features.
Hmm.
Thank you. That sets the stage nicely. Let's dive into the first main segment then and really unpack some of these common problems, starting with the rotator cuff.
Right, the rotator cuff. It's often talked about as if it were a single thing, a single muscle perhaps.
Yes, just the cuff.
But it's actually a group of 4 distinct muscles.
Hmm.
The supraspinatus, infraspinatus, teres minor, and the subscapularis, which sits at the front.
Okay, 4 of them.
And these aren't just passive support structures. They are the dynamic workhorses for most shoulder movements,
Hmm.
particularly rotation, turning the arm in or out and lifting the arm out to the side, abduction.
Right.
They work together in a really coordinated fashion to keep the head of the arm bone, the humerus, centered in that very shallow socket as you move your arm around. Dynamic stability.
Okay, so how do their individual roles differ if there are 4 of them?
Well, broadly speaking, the supraspinatus, which runs over the top, is key for initiating that lifting motion, abduction.
Starting the lift.
Yes. Then the infraspinatus and the teres minor, they're situated at the back, and they're your primary external rotators, crucial for movements like, say, throwing a ball or getting your hand behind your head.
Okay, rotating outwards.
And the subscapularis at the front is the main internal rotator, used for things like reaching behind your back or doing up a bra strap, that sort of motion.
Got it.
And the structure of their tendons is also interesting. The sources mention some variations, like the supraspinatus having mostly a single tendon merging into the main cuff structure, while the subscapularis actually has multiple sort of independent tendinous bands converging together.
And this anatomical detail is important because it links to how clinicians test the cuff, using specific physical tests to pinpoint which part might be weak or torn.
Exactly that. A good physical examination is invaluable. For the subscapularis, for instance, because its internal rotation action can sometimes be hard to isolate purely, special tests are used.
Like the liftoff test.
Precisely. The liftoff test, where you try to lift your hand away from your lower back, that position is designed to isolate the subscapularis. If you can't even get your hand into that position because of stiffness,
Which can happen.
yes, then alternative tests, like the belly press, pressing your hand into your stomach, or the bear hug test are used. They're still aiming to test that specific internal rotation function, just in a different way. And for the teres minor, which is one of the external rotators at the back, there's the dropping sign. The examiner passively rotates the arm outwards and then asks the patient to hold it there. If they can't, and the arm drops back inwards, that suggests a problem with the teres minor.
That helps clarify how those specific tests are really trying to isolate the different parts of the cuff. It's quite clever.
It is. It requires careful technique.
Beyond the exam, though, imaging is clearly essential for diagnosis, isn't it? To actually see the tear.
Oh yes, imaging is key, both to confirm the presence of a tear and, crucially, to understand its characteristics. MRI is the standard, really.
And how does the tear show up?
Well, on MRI, healthy tendons appear dark, low signal. Fluid or swelling, on the other hand, shows up bright, high signal. So a full thickness tear, where the tendon is completely separated, torn right through.
A proper gap.
Yes. That will show up as a bright area where the dark tendon should be, indicating that joint fluid has filled the gap. And MRI is also great for assessing the muscle itself. You can see if the muscle belly is shrinking, what we call atrophy, or if it's starting to get fatty infiltration. Both are bad signs for potential recovery, whether conservative or surgical.
What about smaller tears, then? Ones that don't go all the way through the tendon. Partial tears.
Good question. For partial thickness tears, which are actually quite common, especially in athletes, MR arthrography is often very useful.
Arthrography, that involves an injection.
It does. It involves injecting a contrast dye, usually gadolinium-based, directly into the shoulder joint before the MRI scan. If there's a partial tear on either the top surface or the underside of the tendon, the dye seeps into that defect.
Making it visible.
Exactly. It makes even small or subtle partial tears clearly visible on the scan, especially on certain sequences. The sources even discuss the optimal concentration, the dilution of the dye for this, to make sure the tear stands out clearly without obscuring other details.
So imaging really helps confirm and characterize the tear in detail. Now, shifting gears slightly, there's been a lot of discussion over the years about why these tears happen in the first place.
The etiology.
I've often heard about the shape of the bone above the cuff, the acromion being a factor, the idea of impingement.
Ah, yes, the long-standing impingement hypothesis. The idea, originally proposed by Dr. Neer, was that a particular shape of the acromion bone may be hooked or curved downwards, a type 2 or type 3 acromion, could rub or impinge on the rotator cuff tendon underneath, especially the supraspinatus, during arm elevation. And over time, this rubbing could lead to fraying and eventually a tear.
That sounds plausible.
It does sound plausible, and it held sway for a long time. However, the sources you've provided present research that actually challenges this idea quite strongly.
Oh, really?
Yes. One study mentioned specifically looked at the actual contact area between the acromion and the rotator cuff during movement, and they found the opposite of what you'd expect from the simple impingement theory.
The opposite? How so?
Shoulders with rotator cuff tears actually had, on average, a larger contact area between the acromion and the tendon compared to shoulders without tears.
That's really counterintuitive. So the bone wasn't necessarily pinching the tendon more in torn shoulders?
Precisely. At least not in the way that simple theory predicted. This research suggests that just classifying the acromion shape type 1, 2, 3, 3 isn't actually a very reliable predictor of who will get a tear, and that the mechanical impingement idea, at least based purely on the static shape of the acromion, might not be the primary driver of most degenerative cuff tears, as many have assumed for years.
Wow.
It's a really good reminder that our understanding in orthopedics is constantly evolving based on new research and better ways of looking at things. Degenerative tears are likely multifactorial age, genetics, blood supply, load.
That fundamentally shifts how we might think about the cause, doesn't it? If it's not simply the acromion shape causing it.
It does. It suggests intrinsic factors within the tendon itself might be just as, if not more, important.
So, if the cause is complex, what factors then do guide treatment decisions? Is surgery always required for a tear?
Not at all, no. The sources really emphasize that treatment has to be tailored to the individual patient. Most people seek treatment because of pain. That's the main driver.
Makes sense.
And conservative management is very often the initial approach. Now, the goal here isn't necessarily to heal the tear itself anatomically,
All right, you said that earlier.
but rather to make a painful tear become asymptomatic, meaning you might still technically have a tear on an MRI scan, but it doesn't cause you significant pain or limit your function for daily life. Convert a painful tear to a non-painful one.
And how often does that approach actually work?
Well, the sources cite studies showing quite high satisfaction rates with conservative treatment. One study found around 82% of patients were happy with their outcomes without surgery.
That's a pretty good success rate.
It is. And the materials highlight key factors that predict success with conservative treatment. Things like if there's minimal muscle wasting, minimal atrophy in the supraspinatus muscle on the MRI, if specific clinical impingement tests, like the Neer or Hawkins signs, are negative.
Which suggests maybe the pain isn't coming from where those tests provoke.
Exactly. Also, if external rotation strength is well preserved, and if those intramuscular tendons we mentioned earlier, the little tendons within the muscle belly, look intact on the MRI, the big takeaway is that if the key muscles, particularly the supraspinatus and infraspinatus, are still functioning reasonably well despite the tear, then conservative treatment is much more likely to succeed.
Okay, that gives a clear picture of when non-surgical options are promising. So when is surgery indicated then?
Surgical repair becomes the recommendation when conservative treatment fails to provide adequate pain relief or restore function after a reasonable trial, maybe 3-6 months.
Right.
It's also strongly considered for younger and middle-aged patients who are active or have high-demand jobs or sports where optimal function is crucial.
Because they need that strength back.
Precisely. And also, there's the concern that the tear might get bigger over time if left untreated. The sources note a significant risk of tear progression. Perhaps 50–60% of tears enlarge over time.
Oh, wow.
And importantly, the prognosis for surgical repair, the chance of the tendon healing successfully after surgery, is much better for smaller tears. Their data, for instance, shows 0% re-tear rates for small tears that were repaired.
0%. That's impressive.
But that figure can climb dramatically for larger tears. Re-tear rates can be as high as 75% for massive chronic tears where the tissue quality is poor.
75%. Goodness.
Yes. So there's a strong argument for considering earlier surgical intervention in suitable patients younger, active, with good tissue quality before the tear enlarges significantly or the muscle deteriorates beyond repair. Size really does matter for surgical success.
That makes perfect sense. Intervene when the chances of successful healing are highest. Right, let's move on to that other common and often incredibly frustrating condition, frozen shoulder. You clarified earlier it's a very specific diagnosis.
Absolutely. It's quite distinct from other causes of shoulder stiffness, like arthritis or post-surgical stiffness. The consensus definition, as we said, is primary idiopathic stiff shoulder.
Idiopathic unknown cause. primary arises on its own.
Spot on.
Huh.
And it's essentially the same condition, sometimes called 50 shoulder in Japan, which gives you a clue about the typical age range affected, often 40s to 60s.
Right.
And just to reiterate, expert groups really advise against using terms like adhesive capsulitis because the underlying issue isn't primarily those sticky adhesions between the main joint surfaces that the name implies.
Okay, so if it's not inflammation or adhesions in the way we might think, what is actually happening inside the joint capsule?
The primary problem seems to be a profound thickening and shortening, a contraction of the joint capsule itself, particularly in the bottom part, the bit called the axillary pouch. It just sort of shrinks down.
The capsule itself changes texture.
Yes. The sources reference studies that use special stains, like Alcian blue, when looking at biopsied capsular tissue. And these reveal changes within the capsule that suggest a process more akin to scar tissue formation, what we call fibrosis, or even cartilage-like changes, chondrogenic metaplasia.
Wow.
It's not just simple inflammation.
Wow, so the tissue fundamentally changes.
It seems so. And this thickened, contracted capsule significantly reduces the overall volume of the joint space. It just becomes tighter.
Which brings us back to that negative pressure idea you mentioned earlier for stability, doesn't it?
It absolutely does. That reduced joint volume makes it much harder for that helpful negative intra-articular pressure mechanism to work effectively. The suction effect is lost or diminished, contributing to the feeling of stiffness and the restricted movement.
Okay, that fits.
And here's a really interesting connection the sources highlight, which you touched on earlier. There's research suggesting a potential link between the development of frozen shoulder and posture.
Posture. How?
Well, one study showed that scapular internal rotation, where the shoulder blade tips forward, which can happen with increased rounding of the upper back, thoracic kyphosis as we age.
Slouching posture, essentially.
Kind of, yes.
Yeah.
This posture was shown to decrease blood flow in a specific artery near the shoulder joint, the anterior humeral circumflex artery. And the theory is that this reduced blood flow might play a role in triggering or worsening the pathological changes in the joint capsule that lead to frozen shoulder.
Wow. Connecting upper back posture to blood flow changes and then potentially to a frozen shoulder, that's a connection I certainly would never have made.
It's quite thought-provoking, isn't it? Suggests a more systemic element, perhaps.
Definitely. So how do clinicians diagnose frozen shoulder definitively then and rule out other things?
Well, it's often described as a diagnosis of exclusion initially, meaning you have to rule out other potential causes of stiffness, like underlying arthritis, maybe a large rotator cuff tear causing pseudoparalysis or post-traumatic stiffness. The physical exam is key. It typically shows significantly limited range of motion, both when the patient tries to move active and when the examiner moves the arm passive. External rotation is almost always the most restricted movement.
And imaging helps confirm?
Imaging helps confirm the diagnosis and, importantly, exclude those other conditions. Plain X-rays are usually normal in frozen shoulder itself, but they're essential to check for arthritis or other bone issues. Arthrography, injecting dye.
The same test used for partial cuff tears.
Yes, but used differently here. In frozen shoulder, the arthrogram shows a characteristic marked reduction in the joint volume. You simply can't inject much dye compared to a normal shoulder, and you often see obliteration of the normal pouches and the sheaths around tendons like the biceps. Sometimes the capsule even ruptures during the injection because it's so tight.
Goodness. And on MRI, is that preferred?
MRI is generally preferred now as it's non-invasive and gives great soft tissue detail, shows the same key features. The thickened joint capsule, particularly the inferior part, and that characteristic obliteration or loss of definition of the axillary pouch. The space just isn't there. It can also show changes around the biceps tendon sheath.
Are there any specific signs on MRI to look for?
Yes, a specific MRI finding mentioned in the sources is the subcoracoid fat triangle. This is a little triangle of fat normally visible just under a bony prominence called the coracoid process, seen on certain angled MRI views. In frozen shoulder, this fat pad often gets compressed or disappears completely because the thickened capsule squashes it.
Ah, a subtle sign.
It is. And that, along with measurable thickening of another part of the capsule called the coracohumeral ligament, usually measuring over 4 millimeters thick in frozen shoulder, are considered quite specific and characteristic signs when seen together with the clinical picture.
So specific imaging signs point strongly towards this specific condition. And what about treatment? How successful is it?
Well, similar to many shoulder issues, conservative treatment is actually highly successful for the vast majority of frozen shoulder cases. The sources mentioned reported success rates as high as 93–95% with physical therapy.
That high. That's encouraging.
It is. The focus of physiotherapy is on gradually regaining that lost range of motion through specific stretching exercises. It can take time, sometimes many months, even up to a year or two for full resolution. But most people do improve significantly with structured therapy in patients.
What if conservative treatment just isn't working after, say, 6 months or a year?
For the small minority of cases, typically estimated around 5–7% that remain severely stiff and painful, despite a good trial of conservative treatment for maybe 6 to 12 months, then intervention is considered.
Okay.
This usually means one of two things: manipulation under anesthesia,
Mm.
or MUA, or an arthroscopic capsular release.
Are there factors that predict who might need intervention?
Yes, the sources mention some risk factors for a poorer response to conservative treatment. Having diabetes is a known factor, as is presenting with very severe contracture right at the initial visit, for example. If you can barely lift your arm forward to 90 degrees or have zero external rotation, those patients may be more likely to eventually need intervention.
How does manipulation under anesthesia actually work? It sounds a bit forceful.
Well, while the patient is asleep under general anesthetic, the surgeon gently but firmly moves the arm through its range of motion flexion, abduction, rotation to manually tear the thickened, contracted capsule and break up any minor adhesions.
Just physically tearing the tight tissue?
Essentially, yes. It's important, the sources note, not to do this during the very early, intensely painful freezing phase, but rather later when the severe pain has subsided somewhat, but the stiffness persists. It does carry some risks, including potential fracture or nerve injury, though the complication rates mentioned are relatively low, around 3–5%.
How do they minimize those risks?
Techniques involve using a shorter lever arm, holding closer to the shoulder rather than the wrist, and performing the movements gently, slowly, and in a controlled manner, feeling for the release rather than forcing it aggressively.
And the alternative is arthroscopic release. That's a surgical procedure.
Yes, that's a keyhole surgical procedure. Using a camera and small instruments inserted into the joint, the surgeon visually identifies the thickened, tight parts of the capsule and carefully cuts through them, releasing the restriction.
So it's more targeted.
It's generally considered more precise, yes. You can release the tight tissue around the clock, often starting anteriorly, then inferiorly in the axillary pouch, and sometimes posteriorly as well, while trying to preserve other important structures like the rotator cuff tendons.
And after either of these procedures,
After either MUA or arthroscopic release, aggressive and immediate physical therapy is absolutely crucial. The goal is to maintain the new range of motion that has been gained during the procedure and prevent the capsule from tightening up again. Consistent stretching is key postoperatively.
that gives us a really clear picture of two very common but quite distinct conditions. And understanding the specific pathology really informs the best treatment path, doesn't it?
It absolutely does. Accurate diagnosis is paramount.
Right. Now let's pivot slightly. We've talked about common ailments. Let's move towards the mechanics of stability itself and how that plays out in more dynamic situations, particularly thinking about throwing athletes.
Yes, the mechanics of stability are fascinating. As we touched on right at the start, the shoulder has this incredible range of motion, the greatest of any joint in the body.
More than any other joint.
Yes. But paradoxically, it's also the most frequently dislocated major joint, accounting for almost half, maybe 45%, of all traumatic dislocations.
That seems like a real contradiction. Huge movement, but easy to dislocate.
It does. And this apparent contradiction is largely explained by its bony anatomy. It's often described using the analogy of a golf ball sitting on a very small golf tee.
Okay, I can picture that.
The head of the humerus, the ball, is large and round. The glenoid socket on the shoulder blade, the T, is relatively small, shallow, and flat.
So it allows for lots of movement, but lacks inherent bony stability.
Precisely. That bony mismatch is what allows for the huge potential movement arc. But it means the joint relies very heavily on other structures, the soft tissues, for its stability. It doesn't have the deep socket constraint of, say, the hip joint.
So what are these other structures then? The ones actually holding the golf ball on the tee?
It's a combination of passive and dynamic elements working together. Passively, as we mentioned, the extreme end ranges of motion, the joint capsule and its thickenings, the ligaments, particularly that important inferior glenohumeral ligament complex.
The IGHL complex.
Yes, the IGHL complex, which has anterior and posterior bands and the axillary pouch in between. These tighten up right at the end of the movement arc to prevent the head from sliding too far off the glenoid.
So they act like static ropes at the limit.
Kind of, yes. The sources describe how different parts of this ligament complex become taut in different positions. For example, The anterior band of the IGHL tightens significantly when you raise your arm out to the side and rotate it outwards, abduction and external rotation, which is, not coincidentally, the most common position for an anterior dislocation.
The position where it's most vulnerable.
Exactly. And then there's that negative pressure effect we discussed earlier, the intra-articular pressure.
The suction cup effect.
Yes. That's thought to be a crucial mid-range passive stabilizer. When you're not at the very end of your motion, that slight negative pressure inside the field joint space helps to suck the humeral head firmly into the socket, providing stability during everyday movement.
And for that to work well.
For that to work well, the joint volume needs to be just right. Studies mentioned in the sources show that reducing the joint volume surgically, making the space tighter, significantly increases this negative pressure effect, which boosts stability. The capsule also needs to be relatively intact and have the right elastic properties.
So conditions that affect the joint volume or the capsule's integrity would impact this suction mechanism.
Absolutely. A classic example is multidirectional instability, or MDI. Patients with MDI often have a larger than normal joint volume, a more capacious joint, and often a naturally thinner, more flexible capsule.
Looser ligaments, essentially.
Yes, often generalized ligamentous laxity. This combination makes it very difficult for them to maintain that negative pressure effect effectively. This can lead to the head of the humerus sitting slightly low in the socket, especially when the arm muscles are relaxed, creating what's called a sulcus sign, a visible dip just below the acromion bone.
I see. And surgical procedures for MDI?
Surgical procedures for MDI, like a capsular shift or capsular percussion, often involve deliberately reducing the joint volume by overlapping and tightening the capsule, aiming to restore that passive stability mechanism, including the negative pressure effect.
That's a very clear link between the underlying mechanics and a specific clinical condition and its treatment. What about traumatic dislocations then, where the joint comes completely out due to an injury?
Traumatic dislocations, most commonly anterior or forward dislocations, about 97% of them, usually involve significant injury to those passive stabilizers. Typically, the labrum, that cartilage rim around the socket, which deepens it slightly, gets torn away from the front of the glenoid bone, along with the attached capsule and ligaments.
That's the Bankart lesion.
That's the classic Bankart lesion, yes. Often there's also damage to the back of the humeral head, where it impacts the glenoid rim. During the dislocation, that's the Hill-Sachs lesion we'll come back to. Now, while there's a technical difference between a full dislocation, where the joint surfaces completely lose contact, and a partial subluxation, where they slide abnormally but pop back in.
Right.
Clinically, the term instability is often used to cover both, as the underlying pathology and the principles of assessment and treatment are quite similar. A key symptom for patients is often that feeling of apprehension, that sensation the shoulder is going to pop out again, particularly when they put their arm back into that vulnerable abduction and external rotation position.
Understandable. How long does it typically take for a torn structure like a Bankart lesion to actually heal?
That's a really important question for guiding treatment and rehabilitation. The sources reference research looking at tissue healing rates. A study in rabbits, for example, looked at surgically created Bankart lesions. They found histological evidence of healing within about 3 weeks, and the mechanical strength returning to near normal by about 4 weeks.
By rabbits.
In rabbits, yes. Now, obviously, humans heal slower. A rough guide sometimes used is to multiply rabbit healing times by about 3 or 4 based on comparisons with fracture healing. So extrapolating from that animal data suggests that a Bankart lesion likely takes around 3 months or so to achieve significant structural healing in a human.
Okay, about 12 weeks.
Roughly. And this time frame aligns pretty well with typical rehabilitation protocols that allow athletes to start returning to sport around 3 months after a surgical Bankart repair, assuming healing progresses well.
3 months still seems quite rapid given the forces involved in sports. There's also been quite a significant change in practice regarding how to immobilize a shoulder immediately after a first-time dislocation, hasn't there? The sling position.
Yes, absolutely. For decades, the standard practice worldwide was to put the arm in a simple sling, holding the arm across the body in internal rotation.
The classic sling position everyone recognizes.
Exactly. However, studies emerged, initially using MRI scans and also looking at cadaver shoulders, which showed something quite crucial. In that traditional internal rotation position, a torn Bankart lesion is often held wide open. The torn labrum and capsule are separated from the bone where they're supposed to heal.
So it's not in a good position for healing.
Not at all. But these studies showed that when the arm is instead positioned in external rotation, rotated outwards away from the body.
The opposite way.
Yes. The torn labrum and ligaments are better reduced, meaning they lie back closer to their normal anatomical position against the glenoid bone. This suggested that immobilizing in external rotation might promote better healing.
And did clinical trials support that?
They did. A large prospective randomized controlled trial then confirmed this. It showed that immobilizing first-time dislocators in external rotation significantly reduced the rate of redislocation compared to the traditional internal rotation sling.
So holding the torn tissue in a better position really does help it heal better and reduce recurrence.
Exactly. The challenge then became finding the optimal position for this external rotation immobilization that patients could actually tolerate. Studies explored different degrees of abduction, lifting the arm away from the side, and external rotation. They found that while positions like 30 degrees of abduction and maybe 60 degrees of external rotation offered the mathematically best reduction of the torn labrum.
That sounds uncomfortable to maintain.
It was found to be quite uncomfortable and impractical for patients to wear a brace holding them in that much rotation for several weeks. So a compromised position, typically around 30 degrees of abduction and perhaps 15 to 30 degrees of external rotation, was often chosen. It was much better tolerated by patients while still providing a significantly better reduction of the Bankart lesion compared to the old internal rotation sling.
A practical compromise based on solid biomechanical and clinical research. Makes sense. And for those who go on to need surgical repair, what's the standard approach now?
Arthroscopic Bankart repair is now the gold standard for surgical treatment of traumatic anterior instability without significant bone loss. Keyhole surgery.
And that's evolved too.
It's evolved significantly over the last few decades.
Mm.
Early arthroscopic techniques were perhaps less robust, sometimes just using sutures passed through the tissue. But modern techniques rely heavily on suture anchors. Yes, these are small devices, usually made of metal or bioabsorbable material, that are inserted securely into the bone of the glenoid rim. The sutures used to repair the torn labrum and capsule are attached to these anchors. This provides much more rigid and reliable fixation of the repaired tissue back onto the bone, leading to better healing and significantly improved outcomes compared to older techniques.
And the sources mention that even where exactly you put those anchors matters. There was something about a dead man theory.
Ah, yes, the dead man theory. That was an older concept based on the analogy of how a tent peg holds best in the ground, inserted at a 45-degree angle to maximize friction. It was thought that suture anchors should also be inserted obliquely at 45 degrees to the bone surface for the strongest fixation.
Sounds logical.
It does. However, the sources, including biomechanical studies conducted by their research group, have actually shown this isn't true for modern threaded suture anchors. These rely more on their screw-like threads gripping the bone rather than just simple friction like a smooth tent peg.
So the analogy doesn't hold.
It doesn't seem to. Their biomechanical tests and subsequent finite element analysis clearly demonstrate that inserting threaded anchors perpendicular to the bone surface provides significantly greater pull-out strength compared to inserting them obliquely at 45 degrees.
Perpendicular is stronger.
For threaded anchors, yes. Significantly stronger, about 16–19% more force required to pull them out when inserted perpendicularly. So for these modern anchors, perpendicular insertion is the way to go, essentially debunking that older dead man theory for this specific application.
Another long-held belief overturned by biomechanical research. Fascinating. What about the situation where there is bone damage associated with the instability? You mentioned the Hill-Sachs lesion, the dent in the ball.
Yes, and also glenoid bone loss.
Yeah.
Where a piece of the socket rim gets chipped off or worn away over time with recurrent dislocations. Bone loss is absolutely critical in shoulder instability.
Why is it so important?
Because it reduces the inherent bony constraint of the joint. It makes the T even smaller or flatter, or creates a defect on the ball that can catch on the rim. This makes the shoulder much more prone to redislocation, particularly when the capsule and ligaments might be a bit lax, especially in that mid-range of motion where the negative pressure effect might also be compromised. If the socket edge isn't there to provide a buttress, or if a dent in the humeral head engages the edge of the socket during movement, it can lever the head out again.
Okay, and this is where that concept of the glenoid tract comes in, which the sources discuss.
Yes, precisely. The glenoid tract concept is a really key development for understanding and managing instability associated with bone loss. The glenoid tract simply refers to the zone or area on the back of the humeral head that normally contacts the glenoid socket throughout a healthy range of shoulder motion, particularly abduction and external rotation.
Okay, the normal contact zone.
Yes. A Hill-Sachs lesion, that dent on the back of the humeral head caused by impact during dislocation, is then classified as being either on track or off track.
On or off, meaning?
It's on track if the entire lesion stays within this normal contact zone during movement. In this case, it's less likely to engage with the front edge of the glenoid and cause redislocation. It's classified as off track if the lesion extends so far medially towards the center line of the head that it can actually fall off the glenoid rim and engage with the front edge of the socket as you move your arm into abduction and external rotation. An off-track lesion acts like a lever, making redislocation highly likely.
I see. So off track is the problematic one. How is that actually assessed clinically?
The sources describe a method that ideally requires 3D CT scans, preferably of both shoulders. The uninjured side helps determine the patient's original glenoid width. Then, on the injured side, you measure the amount of glenoid bone loss, let's call it D. You can then calculate the width of the effective glenoid track. On the injured side, it's roughly 83% of the original glenoid width, D, minus the bone loss D. So track width equals 0.83D.
Okay, a specific calculation.
Yes. You then look at the Hill-Sachs lesion on the CT scan and determine if its medial edge lies within or extends medial to this calculated track width. If it extends medial to the track, it's an off-track lesion. This detailed measurement is crucial because it directly guides the treatment strategy. The sources even cite research showing that patient outcomes measured by scores like the WSI score are significantly worse if the Hill-Sachs lesion engages near the edge of the track.
So, based on these detailed measurements on track versus off track and the amount of glenoid bone loss, there's a specific treatment algorithm proposed.
Exactly. The sources present a very clear treatment paradigm based on these two key factors. Is the Hill-Sachs lesion on track or off track? And is the glenoid defect small, less than 25% of the socket width, or large, greater than or equal to 25%?
Okay, walk us through that.
Right. If the Hill-Sachs is on track and 80 glenoid defect is small, 25%, then a standard arthroscopic Bankart repair is usually sufficient to restore stability. The bone loss isn't critical in this scenario.
Makes sense.
If the Hill-Sachs is still on track, but the glenoid defect is large, 25%, then simply repairing the soft tissues isn't enough. You need to address the significant bony deficit on the socket side. This usually requires a bone graft procedure like the Letarjet procedure, which transfers a piece of bone, the coracoid process, to the front of the glenoid to effectively widen it.
Okay, rebuild the socket edge.
Exactly. Now, for the more problematic off-track Hill-Sachs lesions, if the Hill-Sachs is off track, even with a small glenoid defect, 25%, you have to address the engagement issue. You can't just do a Bankart repair alone.
So what are the options?
The options are typically either the Letarjet procedure again, because by widening the glenoid, it effectively makes the glenoid track wider and can convert an off-track lesion to an on-track one relative to the new socket edge. Or you could combine a standard Bankart repair with a procedure called remplissage.
Remplissage, what's that?
Remplissage is French for filling. It involves arthroscopically stitching the infraspinatus rotator cuff tendon and the posterior capsule down into the Hill-Sachs defect on the back of the humeral head. This effectively fills the dent and prevents it from engaging the glenoid rim.
Filling the hole.
Yes. The sources note a preference towards Letarjet for off-track lesions, partly because remplissage can sometimes lead to a bit of stiffness, particularly loss of external rotation. But they acknowledge that Bankart plus remplissage is a valid alternative, especially if a patient strongly wishes to avoid the bone transfer involved in the Letarjet.
Okay, providing options. And the last scenario. Off-track Hill-Sachs and a large glenoid defect.
That's the most severe combination. Usually, a Letarjet procedure is performed to address the large glenoid defect. Often, this alone is sufficient to make the Hill-Sachs lesion effectively on track relative to the augmented glenoid. However, if the Hill-Sachs is extremely large and remains off track even after the Letarjet, then occasionally a remplissage might need to be added, or an even larger bone graft, perhaps from the iliac crest, might be considered for the glenoid.
It's a really specific, tailored approach driven entirely by the detailed assessment of the bone loss on both sides of the joint.
It is. It represents a significant shift towards bone-focused management for complex instability.
And you've actually seen this specific approach work well in practice.
Yes. The evidence is compelling. The sources mention a study that prospectively applied this treatment paradigm based on the glenoid track concept. They found excellent results. A very low recurrence rate, around 5%, for the on-track lesions treated appropriately with Bankart repair, and importantly, 0% recurrence rate for the off-track lesions that were treated according to the algorithm with Letarjet or Bankart plus remplissage.
0 recurrence for the off-track group. That's incredible.
It's very strong evidence supporting the effectiveness of using these detailed bony assessments and tailored surgical approaches for instability with bone loss. It really seems to address the underlying mechanical problem effectively. The Latarjet procedure itself, by the way, has gained huge popularity worldwide recently for treating these complex cases, thanks largely to the work of surgeons like Gilles Walch in Lyon, building on the original description by Michel Latarjet.
That's compelling data and a fascinating evolution in treatment strategy. Now, let's narrow our focus even further to the specific demands placed on the shoulder during certain activities, particularly the throwing shoulder seen in athletes.
Right. The throwing motion is perhaps one of the most demanding and unnatural actions we ask the shoulder joint to perform, especially in sports like baseball, cricket, javelin, tennis.
The speeds involved are incredible, aren't they?
They really are. Think about the acceleration phase of a baseball pitch. The peak internal rotation velocity of the humerus can reach over 7,000 degrees per second. That's arguably the fastest recorded human movement.
7,000 degrees a second. Wow.
And the forces involved, particularly during the deceleration phase, as the arm slows down after ball release, are immense. The distraction force trying to pull the arm out of the socket can be equivalent to 1 to 1.5 times the athlete's body weight.
Huge forces.
Huge forces, huge velocities, repeated thousands of times. It's no wonder that these extreme demands lead to a distinct spectrum of injury patterns, often related to the specific phase of the throwing motion where the stress occurs.
So you get injuries specific to different parts of the throw.
Exactly. For example, in the late cocking phase, when the arm is maximally externally rotated, way back.
The windup.
Yes. The anterior capsule and ligaments are under maximum tension, which can lead to stretching, microtrauma, or even frank instability over time. Then, the rapid whip-like motion of the acceleration phase puts enormous stress on the rotator cuff tendons and the labrum, potentially causing tears.
Okay.
During the follow-through, as the arm rapidly decelerates, you get both traction forces and compression forces within the joint. This phase is often associated with injuries like SLA tears, tears of the superior labrum, where the biceps tendon attaches Bennett lesions, which are bony spurs on the back of the shoulder socket, and also posterior impingement symptoms.
So different phases stress different structures.
Precisely. And in young athletes whose growth plates haven't closed yet, particularly adolescent pitchers, the repetitive stress across the proximal humeral growth plate can cause it to widen or even slip, a condition known as a little leaguer's shoulder or proximal humeral epiphysiolysis.
Ouch, that sounds painful. What about GRD? That's something you hear about a lot in throwers, the internal rotation deficit.
Yes, GRRD, or glenohumeral internal rotation deficit, is indeed very common in overhead athletes. It's typically characterized by reduced internal rotation range of motion in the throwing shoulder compared to the non-throwing side. Often, this is accompanied by a compensatory increase in external rotation range on the throwing side.
So they lose inward rotation but gain outward rotation.
Often, yes. Now, it's important to differentiate between two types of GRD. There's physiologic GRD, which is thought to be an adaptive change.
Adaptive, meaning helpful.
Potentially, yes. It's believed to result partly from bony changes that occur during growth in response to throwing. The humerus bone itself might twist slightly differently on the dominant side, developing increased retroversion. This allows for more external rotation, which can be beneficial for throwing velocity and is generally associated with a lower risk of injury.
Okay, so some GRD is a normal adaptation.
Yes. But then there's pathologic GRD. This is thought to be due primarily to soft tissue tightness, specifically tightness in the posterior capsule and the posterior rotator cuff muscles, infraspinatus and teres minor. This tightness develops from the repetitive eccentric loading and stretching these structures undergo during the deceleration phase of every throw.
The braking muscles get tight.
Exactly. This stiffness can initially be temporary, a sort of acute effect called thixotropy, but with repetitive stress over time, it can become fixed, irreversible tightness, leading to that loss of internal rotation. And this pathologic GRD is associated with an increased risk of shoulder and elbow injuries.
So some GRD is an adaptive bony change, potentially helpful, while some is problematic soft tissue tightness. How do you tell the difference?
It's complex and involves careful clinical assessment. Looking at the total arc of rotation, internal plus external rotation, can give clues. Often the total arc is maintained or even increased in physiologic GRD, whereas it might be decreased in pathologic GRD. Also, assessing the quality of the end field during stretching helps differentiate bony block from soft tissue tightness.
Okay. The sources also mention things like the Bennett lesion and SLH tears and throwers.
Yes, the Bennett lesion, that bony spur on the posterior glenoid rim, was previously thought to be due to traction from the triceps tendon, but current thinking, mentioned in the sources, suggests it's more likely a traction osteophyte formed by repetitive stress on the posterior band of the inferior glenohumeral ligament and posterior capsule during the follow-through phase.
And SLAP lesions, the superior labrum tears.
SLAP lesions are often linked to traction by the long head of the biceps tendon, which attaches right onto that superior labrum. A cadaveric study cited measured strain in the labrum during simulated throwing motions. It found the greatest strain occurred in the superior and posterior-superior labrum, right where the biceps anchors, particularly during the late cocking phase. This supports the idea that biceps traction contributes to SLA tears and throwers.
That makes sense biomechanically. Now, this brings us to the part of the source material that I found really quite surprising and perhaps relevant even beyond elite athletes. The findings from epidemiological studies linking shoulder pain to seemingly unrelated factors.
Ah, yes. This is where looking at the broader picture, the large population studies, can really yield fascinating insights. Several studies cited in the sources, focusing on young overhead athletes, particularly baseball players, found remarkably strong associations between experiencing shoulder or elbow pain and having issues elsewhere in the body.
Elsewhere. Like where?
They found significant statistical links between shoulder elbow pain and reporting pain in the back, pain in the hip, pain in the knee, and even pain in the foot or ankle.
Wow. So a young athlete presenting with shoulder pain is actually highly likely to also have pain or issues somewhere in their core or lower limbs.
Exactly that. One study specifically noted that nearly two-thirds, around 61%, of the young athletes who reported having back pain also reported experiencing shoulder or elbow pain.
That's a huge overlap.
It really highlights the concept of the kinetic chain in throwing. Throwing is a whole body activity. Power is generated from the ground up, legs, hips, trunk rotation, and then transferred up through the shoulder and arm to the ball. If there's a weak link anywhere lower down in that chain, poor core stability, weak legs, limited hip mobility.
The shoulder and elbow have to compensate.
Precisely. The upper extremity ends up taking on excessive stress to generate the required velocity, increasing the risk of injury. It means that when evaluating an athlete with shoulder pain, you absolutely have to assess the entire kinetic chain. Treating the shoulder in isolation often misses the underlying biomechanical issue.
And flexibility in other areas matters too, not just pain.
Yes, absolutely. Another study focused specifically on hip rotation. It found that having a significant restriction in hip internal rotation in the stride leg, the leg that lands forward when throwing, was significantly associated with having shoulder or elbow pain in elite young baseball players. Those with pain had, on average, about 8 degrees less hip internal rotation on that side compared to those without pain.
Less hip rotation linked to arm pain.
Yes. It suggests that limited flexibility elsewhere in the kinetic chain can be an intrinsic risk factor for upper extremity injury, perhaps by altering the mechanics further up the chain.
Okay, this is all pointing towards a very holistic view. But now, prepare for the really surprising nugget. The one that apparently even made headlines. The association with video games.
Expert speaker gives a slight chuckle. It does sound counterintuitive at first glance, doesn't it?
Yeah.
But yes, one of the studies included, again looking at elite young baseball players, found a statistically significant association between the amount of time spent playing video games and the likelihood of experiencing shoulder or elbow pain.
How significant was the association?
Players who reported playing video games for 3 or more hours per day were found to be 5.5 times more likely, an odds ratio 5.59, to report having shoulder or elbow pain compared to those who played for less than 1 hour per day.
5.5 times more likely, just from playing video games. That's extraordinary.
It is quite a striking finding. And what's interesting is that the same study found no significant association between the hours spent watching television and shoulder elbow pain.
So it's specific to gaming, not just screen time in general. What could possibly be the mechanism here? The sources must have speculated.
They did propose a couple of potential mechanisms. Firstly, unlike relatively passive TV watching, video gaming, especially intense or competitive gaming, involves active physical engagement, concentration, and often highly repetitive fine motor movements of the hands, wrists, and arms.
Button mashing, mouse clicking.
Exactly. This prolonged active engagement could lead to muscle fatigue and stiffness, particularly in the postural muscles supporting the neck and shoulder girdle, like the trapezius muscle. Stiffness and fatigue in these scapular stabilizing muscles can contribute to abnormal scapular motion or dyskinesis.
Okay, muscle fatigue from the activity itself. What else?
Secondly, and perhaps just as importantly, is the issue of posture during prolonged gaming. Players often adopt poor posture, typically gazing downwards at a screen, leading to sustained neck flexion and a rounded upper back posture, increased thoracic kyphosis.
The classic gamer slouch.
Pretty much. And we know that this kind of forward head, rounded shoulder posture negatively impacts normal scapular mechanics. It can restrict upward rotation and cause tilting of the scapula, which in turn can narrow the subacromial space and potentially increase the risk of impingement issues, especially in an overhead athlete who already stresses that area.
So it's potentially a double whammy.
Mm-hmm.
Direct muscle fatigue and stiffness from the active gaming movements, combined with the detrimental effects of prolonged poor posture on the shoulder's foundation, the scapula.
That seems to be the hypothesis, yes. A combination of factors leading to dysfunctional shoulder mechanics.
It's no wonder, then, that the sources mentioned a Wall Street Journal article ran with a headline something like, "The latest threat to pitchers' arms could be Fortnite."
It perfectly illustrates how these seemingly disconnected lifestyle factors, things happening completely away from the sports field, can have a tangible impact on physical performance and injury risk, especially in athletes who place such high demands on their bodies. And importantly, unlike genetics or age, these are potentially modifiable risk factors.
Absolutely, things we can actually address. So when it comes to treating these throwing-related injuries, particularly when these whole body or lifestyle factors might be involved, is the approach just rest and standard rehab?
Rest, especially acute rest from throwing, is certainly an important component initially. But the overall treatment needs to be a comprehensive conservative management program. This absolutely includes targeted physical therapy, but also things like adhering to pitch count guidelines and rest periods for young players, ensuring proper warm-up and cool-down routines are followed, and incorporating appropriate stretching.
Okay.
Crucially, for pitchers, it often involves working closely with a multidisciplinary team, coaches, therapists, perhaps biomechanists, to identify and correct any flaws in their pitching mechanics that might be contributing to the excessive stress on the shoulder or elbow. Technique is key.
And what kind of physical therapy exercises are particularly important for these athletes?
Strengthening the rotator cuff itself is vital, of course, but there's a huge emphasis on strengthening the muscles that control and stabilize the shoulder blade, the parascapular muscles.
The scapular stabilizers again?
Yes. Many throwing athletes develop abnormal scapular motion, often showing excessive upward rotation or elevation during throwing. So exercises need to specifically target muscles like the lower trapezius and the serratus anterior, which help control these movements. Examples mentioned include things like side-lying external rotation or prone shoulder extension exercises, consciously trying to minimize overactivation of the upper trapezius.
Engaging the right muscles.
Exactly. And dynamic exercises that involve coordinated movement patterns, like the lawnmower exercise described in the sources, which simulates pulling a starting cord on a lawnmower, involving rotation and scapular retraction depression, can be particularly useful for getting greater activation of that lower trapezius compared to more static exercises.
Okay. And what about addressing the tightness, that pathologic GIRD?
Stretching is very important, particularly focusing on the posterior capsule and posterior cuff to improve internal rotation. The sources discuss common stretches like the sleeper stretch, lying on your side and stretching the back of the shoulder, and the crossbody stretch, pulling the arm across the chest.
One better than the other.
Interestingly, a meta-analysis cited found that the crossbody stretch actually produced slightly more immediate improvement in internal rotation range right after stretching compared to the sleeper stretch. So perhaps focusing on the crossbody stretch might be particularly beneficial.
Good tip.
And linking back to the posture issue, if an athlete has increased thoracic kyphosis, exercises focused on improving thoracic extension mobility and strengthening the upper back extensor muscles are also recommended as part of the overall program.
It's clear that successfully treating the throwing athlete is about much more than just fixing a specific structure in the shoulder itself. It really is about optimizing the entire kinetic chain and even addressing posture and potentially lifestyle factors.
Absolutely. It has to be a whole-body, holistic approach. You can't just focus on the site of pain.
We've covered a huge amount of absolutely fascinating detail there. Let's try and wrap up with a quick lightning round, just a few rapid insights on some specific related topics mentioned in the sources.
Okay, ready.
First one, the long head of the biceps tendon. It runs right through the shoulder joint. Is it primarily a mover, a stabilizer, or is just mostly a source of pain? What's the latest thinking?
Ah, the LHB. Its exact role at the shoulder is still somewhat debated, actually. While it's clearly a powerful flexor of the elbow and supinator of the forearm, its function purely at the shoulder joint is less definitive.
Okay.
Studies measuring muscle activity, EMG, show relatively low engagement of the biceps during most shoulder movements in normal shoulders. However, interestingly, several studies have shown significantly increased biceps activity in shoulders that have rotator cuff tears.
So it works harder when the cuff is torn.
It seems so. This suggests it might step up to play a compensatory role, perhaps acting as a secondary depressor of the humeral head, trying to help stabilize it and prevent it from migrating upwards when the rotator cuff is deficient. The sources also mention morphological studies showing that the LHB tendon itself often becomes wider and thicker in shoulders with cuff tears, but interestingly, without corresponding changes in the size of the main biceps muscle belly. This suggests it's more of a local adaptive change within the tendon in response to altered loading, rather than the whole muscle hypertrophying.
Fascinating. And it's often a source of pain.
Very frequently, yes. Biceps tendinitis, inflammation or degeneration of the tendon within its groove, is commonly found alongside rotator cuff tears and other shoulder pathologies. This pain often improves if the underlying primary pathology, like the cuff tear, is addressed surgically, or if the biceps tendon itself is specifically treated. Of course, if the tendon fully tears and retracts down the arm, you get that classic Popeye sign.
The visible bulge, yes. And that leads neatly to the treatment debate. Tenotomy versus tenodesis for a problematic biceps tendon.
Exactly. Kinetic is simply cutting the tendon at its origin inside the shoulder joint and letting it retract. Tenodesis involves cutting it, but then surgically reattaching it lower down, usually to the humerus bone outside the joint, often in the bicipital groove, or below the pectoralis major tendon insertion.
Why the different approaches?
Well, tenotomy is simpler, quicker, and avoids the need for implants or specific post-op restrictions related to the tenodesis healing. It can be very effective for pain relief, especially in older, lower-demand patients. The sources mention the historical anecdote from Professor Gilles Walsh in France, who apparently referred to the biceps tendon as a potential pain generator in cuff tear patients, finding that just cutting it, tenotomy, could often significantly relieve symptoms. Hence the slightly provocative biceps killer nickname that sometimes arose from that philosophy.
Right, just get rid of the pain source.
Yes. However, tenotomy can result in that Popeye deformity, which some patients find cosmetically unacceptable. It can also sometimes lead to muscle cramping or a feeling of fatigue-related weakness, particularly with repetitive elbow flexion or supination activities. Therefore, tenodesis is often preferred, particularly in younger, more active patients, as it aims to maintain more normal biceps function, prevent the cosmetic deformity, and reduce the risk of cramping. There are various techniques for tenodesis, fixing it high in the groove, low in the groove, or even below the groove, subpectoral tenodesis, each with pros and cons.
A great anecdote illustrating the clinical decision-making. Okay, next lightning question. We talked about suture anchors for Bankart repairs and debunking the dead man theory for angle. So just to be absolutely crystal clear for everyone listening, for modern threaded suture anchors, the insertion angle that provides the best pull-out strength is
Perpendicular. Directly perpendicular 90 degrees to the bone surface you're inserting into. The biomechanical studies cited, including their own group's work and finite element analysis, conclusively show that for these threaded anchors, inserting them straight in provides superior fixation strength compared to angling them at 45 degrees.
perpendicular is better for modern threaded anchors. Got it loud and clear. Final lightning question. Are there any rare but particularly interesting shoulder conditions that you came across in the sources that really underscore some of the fundamental principles we've discussed today, perhaps like the importance of scapular stability?
Yes, absolutely. Conditions like significant scapular winging. This can be caused by injury to the nerves supplying key scapular muscles, like the long thoracic nerve affecting serratus anterior, or the spinal accessory nerve affecting the trapezius. It can also be seen in certain muscular dystrophies, like fascioscapulohumeral muscular dystrophy, FSHD, which specifically weakens those muscles around the face, shoulder blade, and upper arm.
And why is winging such a good illustration?
Because when these crucial muscles that control the shoulder blade are weak or paralyzed, The scapula literally wings out, protruding away from the rib cage, especially during attempted arm movements. This completely disrupts the normal coordinated rhythm and movement between the shoulder blade and the arm bone, the scapulohumeral rhythm, that's absolutely necessary for efficiently and effectively raising your arm overhead.
So the arm simply can't function properly if the scapula isn't providing a stable, controlled base.
Exactly that. These, albeit rarer conditions, provide a really dramatic illustration that the scapula isn't just a passive structure along for the ride. It's the foundational platform for all arm motion. Its dynamic stability and controlled movement are absolutely crucial for normal shoulder function. The sources briefly mention that in severe permanent cases of paralysis, surgical procedures sometimes have to be considered just to try and stabilize the scapula against the ribcage procedures like scapulopexy, tethering it, or even scapulothoracic arthrodesis, fusing it to the ribs, just to provide some basic stability to allow for even limited arm function. It powerfully underscores that fundamental principle. You need a stable base to move a mobile joint effectively.
That's a very powerful illustration indeed of just how integrated the whole shoulder girdle complex is. Thank you. That lightning round provided some really sharp, memorable insights into a few key areas. We have covered an incredible amount of ground in this deep dive, haven't we? Moving all the way from the intricate anatomy of tendons and ligaments through the physics of intra-articular joint pressure, delving into the specifics of advanced surgical techniques, and even uncovering the surprising impact of lifestyle factors like video gaming on injury risk. It's been fascinating. Let's quickly try and distill some key actionable takeaways from all this material for our listeners.
Okay, well, firstly, I think a key takeaway is simply to appreciate that shoulder issues are genuinely complex. It's rarely just about one muscle or one bone being the problem. You really have to understand the intricate interplay between the bones, the ligaments, the joint capsule, and, of course, the dynamic control provided by that crucial rotator cuff muscle group.
Absolutely, it's a system. And secondly, building on that, accurate diagnosis is absolutely paramount. You can't treat effectively if you don't know exactly what's wrong. Leveraging the right combination of careful physical examination tests and appropriate high-quality imaging, particularly MRI or MR arthrography, when needed, is crucial for pinpointing the specific pathology, whether that's identifying the type and size of a rotator cuff tear, confirming the specific capsular changes of frozen shoulder, or quantifying bone loss and instability.
Spot on. Thirdly, it's important to remember that conservative non-surgical treatment is often very effective for many common shoulder problems. Many rotator cuff tears, particularly degenerative ones in less active individuals, can become pain-free and functional without surgery, and the vast majority of frozen shoulders will eventually resolve with dedicated physical therapy in patients.
That's encouraging.
But the flip side of that coin is also understanding the specific factors that indicate when surgery is likely the better or necessary option factors, like patient age, activity level, the specific type and size of a cuff tear, the presence of significant bone loss and instability, or, of course, the failure of a well-conducted course of conservative treatment. Knowing when to proceed to surgery is just as important as knowing when not to.
Definitely. And perhaps the most eye-opening takeaway for me personally from revisiting this material is the emphasis on the holistic view. Shoulder health is inextricably linked to whole body health. We saw clear evidence linking shoulder elbow pain in athletes to issues in the trunk and lower extremities, the kinetic chain. We saw the link between posture and potential mechanisms for frozen shoulder. And we even saw that connection between daily habits like prolonged sedentary screen time, particularly active gaming, and increased risk of upper limb problems in athletes. It really drives home the message. Don't just treat the shoulder in isolation. Look at the whole person, the whole system.
Indeed. The kinetic chain, posture, biomechanics, even lifestyle choices, they all play a surprisingly large and interconnected role in shoulder health and injury risk.
Thank you so much for guiding us through this really intricate deep dive into the shoulder. Your expertise in unpacking all that source material and explaining it so clearly has been incredibly valuable.
It's been my pleasure entirely. It's always rewarding to explore these topics in detail and hopefully provide some clarity on what can be quite complex issues.
And to you, our listener, if you found this deep dive valuable and insightful, please do take just a moment to leave a rating for the show and perhaps share it on LinkedIn or X. It really does help other professionals discover these insights. As we wrap up today, perhaps the most profound thought to leave you with, stemming from everything we've discussed, is just how interconnected our physical selves truly are. Delving into the mechanics and common issues of a single complex joint like the shoulder might just prompt us to reevaluate everything from our approach to fitness, exercise, and posture right through to our daily habits and maybe even our screen time. Something to think about.